And has the COMPARZ trial, which was a non-inferiority trial looking at patient preference, now been published? How has that influenced your decision making? Do you find that the community of patients influences that, or are you sticking with the agents that you have the greatest experience with?
So COMPARZ, as you might know, it's a large non-inferiority trial comparing pazopanib to sunitinib. And nearly 1,100 patients or so were randomized 1-to-1 to each arm. And the primary endpoints were efficacy, and the dosing of the drugs were sunitinib at the standard dose, 50 milligrams on a 28 days on and 14 days off, or 4 weeks on, 2 weeks off regimen, and pazopanib at 800 milligrams daily on a daily basis. There's no break in the regimen. So in addition to looking at the efficacy, quality of life measures were also assessed in the study. So the measurement points were at 4 weeks on the study. So a school of thought is that some people argue that this was biased against sunitinib, but the data shows that patients had a better quality of life, and they did better on pazopanib. The efficacy data is similar. The response rates were in the 20 to 30% range, and side effects or the adverse events were similar to previously reported from the large phase 3 trials.
So has COMPARZ changed your practice?
So in terms of patient preference, I think there was an effect. But I selectively use pazopanib for patients who I need to titrate the dose. Instead of starting at a full dose of sunitinib, which is 1 pill, pazopanib gives me the opportunity to start at 2 or 3 pills daily, and then go up to full dose if they tolerate. So that's one advantage as a practitioner, to titrate it up instead of starting at a full dose and then needing to go to a lower dose. They have to wait for the new script to arrive and everything, things like that.
And so let's also make sure that our audience recognizes the black box warning in these agents.
That's correct.
So being aware that liver toxicity can be life-threatening, how often do you see the patients, whether it's on sunitinib or pazopanib? What do you do when you start to see liver dysfunction? And equally importantly, and Dr. Pal, maybe you can weigh in as well, if you see liver dysfunction and it recovers, what's your next choice?
Right. So that's a great question. You know, it's still a very complex problem to have with both the drugs, but mostly I think it's a little bit more frequent with pazopanib with the data. So if the frequency of visits that I do initially is I bring them after 2 weeks of starting the drug, then recheck the LFTs or with the comprehensive metabolic panel, and then bring them at the 4-week or 5-week mark, and then space it out if they're doing okay. If they do have severe liver dysfunction, including bilirubin abnormality and AST and ALT elevations, then I have to discontinue the TKI use in that situation.
And then you go on to something non-TKI based.
Well, I also have experience switching from one TKI to another does not really cause the same problem. So I've had at least 5 or 6 patients who I switched to sorafenib, and again started at lower dose, hoping not to have the liver toxicity. A lot of them went up to full dose and did not have any problem.
So, but let me just be clear. So, but do you ever go from a pazopanib to a sunitinib, or a sunitinib to a pazopanib after you see liver dysfunction, knowing that they both have black box warnings against that problem?
I have not done that.
Nor have I. Dr. Pal, what do you do in that setting?
Yeah, sure. No, and I'm glad you brought up the issue of liver function tests, because it actually guides my selection of first-line therapy. I think Dr. George and I probably differ a bit in that regard. You know, my interpretation of the COMPARZ trial is, I completely agree, we see balanced efficacy between the two agents. But with respect to safety, There's clearly a difference in the profile. We see an increased risk of liver function test abnormalities with pazopanib relative to sunitinib. In addition to that, perhaps more hand-foot syndrome, but controllable side effects with sunitinib. For that reason, I tend to use sunitinib up front. It's a drug that I'm comfortable with. I can manage the bulk of side effects associated with it via dose reduction or other palliative strategies. Whereas with pazopanib, there's very little that I can do outside of drug discontinuation in the face of severe LFT abnormalities. I would agree that if I saw LFT dysfunction with either, I wouldn't switch to the opposing agent.
So let me